welcome to the Preemie Chats. Preemie Chats is our weekly educational sessions for healthcare professionals and parents to talk about what matters to you, to explore new ideas, and to learn together. I'm Fabiana Bacchini. I am a Preemie parent and Executive Director of the Canadian Premature Babies Foundation, as known as CPBF, and I'm happy to be your host today. CPBF is a parent-led charitable organization to help families in and after their NICU stays through education, support, and advocacy. If you have a heart for preemies, whether you are a family or a healthcare professional, please check our website, canadianpreemies.org. There you'll find resources, the latest project, and most importantly, a community of people who want to see our little babies thrive. If you're watching this live session today, please bring your voice to this table. Leave comments and questions in the chat, and we'll address them during our program. It is through rich conversations like this that we can advance practice and learn together. So please participate and let us know where you're watching from. And today we are going to talk about RSV burden on preterm babies, talk about prevention and new approaches. We will discuss the impact of RSV on preterm babies, why they are at a higher risk of infection, and the challenge they face. And I have here joining me live from Montreal, Dr. Jessie Papenburg, who practices pediatric infectious diseases and medical microbiology at Montreal Children's Hospital. After his specialty training, Dr. Papenburg completed a research fellowship on the molecular virology of respiratory viruses at Laval University and a master in science in epidemiology at McGill. As a clinician scientist, he works on the epidemiology of viral respiratory infections and has over 130 peer-reviewed publications. He actively contributes to national and provincial guidelines on RSV immunoprophylaxis. Dr. Papenburg is also a member of the National Advisory Committee and is the chair of NACI's Influenza Working Group. Dr. Papenburg, thank you so much for joining us here today. This is a very important conversation in a very special season of the year when parents are very anxious about RSV infection. So thank you for being here with us today.
Well, thanks for the invitation. And I understand why, parents there is anxiety around respiratory infections and premature babies. But hopefully, more information will make people feel more empowered and help maybe alleviate some of that anxiety, even though it's something we certainly want to take seriously.
Absolutely. And for all of you watching us live, please do send your questions and we're going to address them at the end of this presentation. Dr. Papenburg, the floor is yours.
Thanks, Fabiana. Okay, so here we go. The objectives of today's presentation are, first of all, to understand the clinical presentation of respiratory syncytial virus infections, RSV, and its disease burden, in particular in premature infants. We're going to try and also summarize some of the RSV prevention strategies that exist, including current but also newer immunizing strategies that are not quite available yet, but should be available very soon. So, RSV. What is RSV? Well, it's a virus that causes cold and flu-like illness. The most common symptoms are runny nose, you can have a decrease in appetite, coughing, sneezing. Fever it can happen, but it's not like influenza where fever is really a classic sign. RSV tends to not really be a febrile illness, or if there is fever, it's usually relatively mild. And wheezing can also be a major symptom in RSV. Now, for most healthy older children, especially outside of the first year of life, and for most adults, RSV infection typically feels like a cold, and we actually get several RSV infections over the course of our lifetime. But in young babies, RSV can be more serious, especially that first infection before the baby has developed any immunity against RSV. That's when there's the greatest risk for RSV to go from the upper respiratory tract, just causing a cold, and get down into the lungs. Now, in Canada, RSV is actually the #1 cause of hospitalizations amongst kids during their first year of life. So really, we see a lot of RSV, not just in pediatric hospitals, but in community hospitals and emergency departments all across the country in the wintertime. So how is RSV spread? RSV is spread like many other respiratory viruses, where there are 3 main ways of spread. One is direct person-to-person contact. So it is the respiratory secretions of the infected person that are infectious. And if for instance, someone has coughed into their hands, you can pass that on by giving a handshake. Or if the person could have some infected secretions on their mouth, and kissing can be a mode of transmission in direct person to person. Then there's also the droplets that are excreted from coughing or sneezing, and they can travel through the air. And for RSV, we think that those droplets tend to travel at most about 2 meters. Now we know that other viruses, maybe like COVID, that transmission can be even further, and maybe it could refer to as airborne transmission. But for RSV, we're pretty confident it's droplet transmissions for about 2 meters. So obviously, somebody who's breathing or coughing or sneezing onto another person, and if those droplets get into the eyes or they get inhaled, that is a chance for transmission. And finally, there can be indirect contact or indirect transmission through objects, such as a toy that has infected secretions on it, doorknobs, cell phones, or other surfaces. And a person who's infected with RSV is usually contagious for about 3 to 8 days. And they can even be contagious before they start showing signs of illness, which is a little bit tricky. And that's true for several respiratory viruses, that we may actually transmit it before we even realize that we're sick. Now, children often get infected with RSV outside of the home, classically children in childcare or daycare or in elementary school. And then those kids are a major source of transmission within the household, and they'll bring the virus to the other members of the family. And obviously, we're concerned about the youngest ones who would be the most vulnerable to having a severe RSV infection. So in children under the age of 5, this is what the burden of RSV looks like overall. It's such a common virus that about half of all kids will have serological or antibody evidence that they have been infected during their first year of life. And then by their second birthday, over 90% of kids have some evidence of having had at least one RSV infection. And as I said, it's that first RSV infection where it's the greatest risk of the virus getting down into the lungs. And then the child will develop either bronchiolitis or pneumonia, which we'll talk about in a little bit. And it's with these lower respiratory tract infections or lung infections of bronchiolitis or pneumonia that we have the most likelihood of then the child requiring medical care. And in the United States, year in and year out, amongst kids under 5, there are about 1.5 million outpatient visits due to RSV, over 500,000 emergency department visits, tens of thousands of hospitalizations, and a few hundred deaths. Now, I'd like to point out that globally, RSV is a major cause of mortality in young children. But thankfully, in Canada and other high-income countries, it's very uncommon for a child to die due to RSV because what they need really is access to supportive care in the hospital to help them through the first few days when they're the most ill. So thankfully, in Canada, we have that supportive care available to our children. Now, bronchiolitis is really a leading cause of hospitalization in kids under the age of 1. And it's a viral infection, most commonly due to RSV, but other viruses can cause bronchiolitis. And it's a viral infection of the small airways in the lungs that we call the bronchioles. And the inflammation caused by the infection then leads to a buildup of mucus, and that mucus can plug the airways. And you can imagine that the smaller the baby, the smaller the airways, and they're therefore more likely to cause some significant plugging that will lead to breathing problems. So that's why it's really in the first months of life, not only because RSV is the first encounter with RSV, but also because the baby's airways are smaller, that they will tend to run into more problems. So that's why severe disease is most common in young infants. As I mentioned, the management of severe bronchiolitis is supportive. We tend not to need to give antibiotics because it's a viral infection. What these children need when they come to hospital is sometimes oxygen. Sometimes they'll be dehydrated because they've been working so hard to breathe that they're no longer able to drink properly, and therefore they might need an intravenous infusion of fluids. We find that some of the youngest babies can sometimes present with apneas or long pauses in breathing. And these are some of the findings that we have on these sicker kids, is that they'll have sharp, dry cough. They can have a change in their color, either being very pale or cyanotic if they're really missing oxygen or not getting enough oxygen exchanged through the lungs. They'll have a bit of a purplish discoloration to them. Their chest can become somewhat hyperinflated because what happens is the air actually winds up getting kind of stuck in the chest due to the plugging of the bronchioles. And they'll have signs of working hard to breathe. In other words, retractions and recessions in between their ribs and above their rib cage. So we know that there are certain chronic medical conditions that place young children at greater risk for developing a complicated RSV infection that requires hospitalization. The table that you see on the left is our results from a study that was performed before the era of immunoprophylaxis with Synagis or palivizumab. So none of these high-risk babies had access at the time to any way to help reduce the risk of hospitalization due to RSV. But I want to point out that, and again, this is important, that it's really young age that is the number one risk factor for hospitalization. So the younger the child, no matter what their condition or if they're a healthy term infant, that's going to be going to have significantly increased risk during those first few months of life. But then if you look at the third column of congenital heart disease, you can see that compared to a healthy term infant, they have roughly 3 times the risk of being hospitalized due to RSV. Whereas a child with bronchopulmonary dysplasia or chronic lung disease of prematurity has several-fold risk compared to a healthy term baby. And I also want to point out that for the conditions of congenital heart disease and prematurity, once a baby gets into their second year of life, they tend to have almost similar types of risk compared to a healthy term baby, at least a healthy term baby during their first year of life. So really, it's that first year of life that's most important for most of these conditions that we should try and prevent RSV infection. But bronchopulmonary dysplasia, these babies have such a low cardiopulmonary reserve. In other words, it doesn't take much of an infection to tip them over the edge in terms of what their lungs and what their heart is capable of dealing with. And they might require hospitalization. And you can see that risk, even in the second year of life, is still twice what it is for a healthy term baby during their first 6 months of life. So really, that's why BPD, or chronic lung disease, tends to be an indication for preventive measures such as Synagis, even in the second year of life. There's a few reasons why the second year of life is less of a risk for RSV hospitalization. We talked about the importance of that first infection being a greater risk for complications compared to subsequent infections, where there's already some degree of prior immunity. And then also, as babies grow, their bronchioles grow, and they're better able to deal with the handling, the secretions, and the mucus and that's caused by the infection. And then the final 3 columns there on the right are for premature babies who don't have any other underlying medical condition. And you can see that certainly there is an increased risk, at least twice compared to healthy term babies, and but there's not a huge gradient in terms of prematurity if you take away the factor of bronchopulmonary dysplasia. So otherwise, healthy preterm babies are at increased risk of RSV during infection and severe infection during their first year of life in particular, but not so much as if they had bronchopulmonary dysplasia. And the graph on the right is really just meant to illustrate how, yes, it's important to look at each individual's baby's risk factors. But if you think about it from a population perspective and the healthcare system perspective, it turns out that over 80% of all children who are hospitalized with RSV, and these are data from Ontario actually, are healthy term babies and with no other risk factor beyond the fact that they were just young. So why is it that premature babies are at higher risk of becoming very sick with RSV? Well, and these are graphics that I pulled from the CPBF website, and it's a great resource for a few things, and I'll highlight those as we go through the talk. But number one is that when babies are born prematurely, their lungs are less mature. So in many ways, so the lung volume will increase. The number of alveoli, and the alveoli are where the gas exchange gets done. So the oxygen gets into the blood and the CO2 gets out of the blood in these alveoli. The number of alveoli increases during the entire gestation and continues actually to increase up until about 8 years of life. So their lungs are less ready because they were born early. And that makes it obviously more difficult for them to deal with an infection once it gets down into the lungs. The second thing is that there actually is what we call a passive transplacental passage of antibodies from the pregnant person to their baby. And that passage of antibodies, those antibodies that help protect newborns during their first few months of life, occurs actually mostly in the third trimester. So after 35, most of it occurs after 35 weeks gestation. So babies who are born before that time don't have that protection that was given to them by their mother that a term baby would have had, or don't have as much protection in terms of those antibodies. Now, baby didn't produce those antibodies themselves. They really were given from during the pregnancy. And over time, those antibodies will degrade, and then baby needs to be able to develop their own antibodies. And we know also that preterm babies, their white cells that produce antibodies are not as good at mounting that immune response also. So there's also the maturation of the white cells that is less they're less mature in premature babies compared to term babies. And then again, and as I mentioned, that they didn't get the gift of those antibodies or as many antibodies from mom because it happens in the third trimester. So these are some Canadian data that we just published from over 5 years of RSV surveillance in 13 pediatric hospitals. And that represented 11,000 hospitalizations over 5 years. And I think the key point here is that half of those hospitalizations were in kids under 6 months of age. So really, we see that the bulk of the burden of disease in those little babies. Now, these are pediatric hospitals, so they're specialized centers with pediatric intensive care units. So really, the sickest patients in Canada will go to these hospitals. And that's why almost 1 in 4 of our patients were admitted to the ICU. But again, I want to highlight that 61% of all the children who needed to go to the ICU for RSV, 61% were less than 6 months of age. So again, the youngest ones are the ones that are going to run into the most trouble. And the slide on the bottom, or the figure on the bottom, demonstrates how the peak incidence of hospitalization, so the most hospitalizations, occurred during the second month of life, so very early. So that's those first 3 months of life. So we really want to do our best to try and protect these our most fragile babies. Now, RSV circulates typically during the winter time, and the figure on the left shows a few years of graphs from Quebec, the province of Quebec, where, yeah, there's a little bit of difference from one year to the next. But overall, you can see that RSV tends to circulate between November to the end of March, roughly, year in and year out. And the other graphs are just to illustrate how at the same time as RSV is circulating, there could be other respiratory viruses circulating as well, such as influenza or human metapneumovirus or the endemic coronaviruses or the common cold coronaviruses. So it's not the only game in town, RSV, but certainly it's the one that affects young babies and premature babies the most. So again, these are Canadian data from those hospitalizations that I was talking about earlier. And I want to show how the the COVID-19 pandemic really affected RSV's seasonality. You can see on the left the three pre-pandemic seasons, with each of those lines representing a different province and their hospitalizations for RSV. And you can see that the provinces, there was a little bit of difference in between them each year, but not really that much. And the hospitalizations really tended to center around the same month. Whereas then in the first year after the pandemic, there were almost no hospitalizations due to RSV. We averaged 2,500 hospitalizations in our network per year for RSV in the pre-pandemic period. And then in 2020-21, that winter, there were only 58. That's a dramatic drop. It was never before seen, such a low number of hospitalizations. But then afterwards, in 21-22, you can see that we had an increase in the number of hospitalizations, up to 3,500 almost. And that was very significant. And, and we also saw that there was more differences in between the provinces. So it kind of highlights that it's important that we follow our provincial recommendations, and the provinces are taking a very close look at what's happening locally to be able to decide when is it that we need to initiate in our province the RSV immunoprophylaxis program. You can see that the big brown curve on the right is Quebec, which had a monster RSV season that peaked in September, October, much earlier than usual, and was completely over by January. So we had to start our palivizumab, our Synagis program early, and we also ended it in January, when normally it runs from November to March. But you can see that some of the prairie provinces had RSV hospitalizations all throughout the spring, and they had to extend their prophylaxis program. So you need to have some flexibility in built into these programs to make sure that we're protecting the babies when RSV is circulating. But what about everyday things that every family can do to help limit the spread of RSV? Well, and I mean spread within the family, but also spread largely in the community. So first of all, I think the pandemic has taught us, well, stay home when you're sick, and also avoid exposing your baby to people that are sick. So really, especially during those first 3 months of life or the first 6 months of life, try and protect your baby, especially if that baby has risk factors for severe RSV, like prematurity, congenital heart disease, or bronchopulmonary dysplasia. We're going to be the most careful for sure. So cover your coughs and sneezes with a tissue or your shirt sleeve, not with your hands, because then you could pass it on with your hands through direct contact. Wash your hands often with soap and water for at least 20 seconds, or use alcohol gel-based rubs. If you're sick and you're caring for your baby, please try and wear a mask if you're being close to them, and avoid kissing them on the face. That's when so the mask will help reduce the droplet spread that we talked about. And obviously, try and not kiss the face, because there could be direct transmission there, a respiratory virus that could be RSV or another virus that could cause problems. In general, especially for at-risk babies, we try to avoid crowds, and we try to avoid daycare. I realize that not all families have that luxury of being able to avoid daycare, but for the higher the risk the infant and the younger they are, the more we'd like to have them stay at home if possible, to delay when they would get their first infection once they're more ready to be able to face it. So that would include also trying to avoid large family gatherings. We try and clean frequently touched surfaces, toys, mobile devices. Protect your baby from secondhand smoke. because we know that secondhand smoke, either during pregnancy or after pregnancy, once the baby's born, increases the risk of any sort of respiratory infection in young infants. And finally, keep your baby's immunizations up to date to have them protected as best you can, including the seasonal influenza vaccine, which babies are eligible for as of 6 months of age. So let's talk a little bit about the medical prevention that we have, injections that are available for RSV prevention. We don't have an active vaccine in babies yet, and I don't know that we're ever going to have one for babies under 6 months of age, but these are the things we currently do. There's a monoclonal antibody called palivizumab or Synagis that's been around for over 2 decades, and it blocks the RSV fusion protein, which is on the surface of the virus, and therefore blocks its ability to replicate and continue to cause its infection. And it really blocks the virus from getting down into the lungs. Most important, it doesn't stop any infection, but it blocks it from getting into the lungs. Now, palivizumab, Synagis, needs to be given monthly injections during the RSV season, and it cuts the risk of hospitalization due to RSV by about 55% in premature babies. And every province has very specific recommendation regarding its targeted use. And we're very careful with the way we use it because it's very expensive, costs somewhere between $5,000 and $8,000 per baby per season. And also it's a monthly injection. So families have to go, bring their high-risk child to the clinic to get the injection every month, which is not a small thing either. So the National Advisory Committee on Immunization has developed recommendations for palivizumab, and I list them here again, kind of highlighting the highest risk groups. But really what's most important is that you look at your provincial recommendations, because these recommendations vary from one province to the next. There can be differences in terms of, how premature a baby needs to have been before for them to be eligible. Some provinces use risk scoring tools for late preterm infants, and differences in the way we maybe define chronic lung disease of prematurity. And I really encourage you to go on the CPBF website, because they have a nice list of each province and their recommendations, and then you can find out if your baby is potentially eligible. And speak to your nurse and your neonatologist, the people who are looking after your preterm baby, and ask them if your baby is eligible for Synagis. Most provinces had hoped to be able to move this year to a new type of antibody called nirsevimab. And the advantages of this new antibody, the main advantage is that it can be given only once. One injection will protect a baby for 150 days or more. So one injection to protect for the whole winter season. And that's a great advantage. And the reason for that is that the antibody has better binding for its fusion protein target. And also it has little modifications on it that allow it to stay intact in the bloodstream for a longer period of time, therefore increasing its half-life and the duration of protection. Now, unfortunately, nirsevimab is not yet available in Canada, even though it was approved for use in by Health Canada in April of this year, 2023. The supply from the producer, Sanofi, is not available yet in Canada, and it's unclear if or when it will be available this season. So for now, all provinces are using still Synagis, palivizumab, for their high-risk infants for immunoprophylaxis. If nirsevimab becomes available, some provinces will switch over to nirsevimab and maybe even be able to give nirsevimab to other infants beyond those that are at highest risk. And that's because nirsevimab was studied not only in high-risk babies, but also in late preterm. It's been studied in preterm infants, in late preterm infants, and term infants. And for all of these patient populations, nirsevimab has been shown to reduce the risk of medically attended RSV lung infection, as well as RSV hospitalizations by roughly 75%. So that's pretty impressive, 75% reduction in RSV hospitalizations in preterm infants and term infants. Eventually, it may be used for all babies during their first RSV season. In fact, that is the authorization from Health Canada. But we're still working on recommendations to see how is it best used in the Canadian context, because there's a lot of things to take into consideration, including the cost of the intervention and is it the most effective use of healthcare resources. But all that to say, I have no doubt that in high-risk infants, nirsevimab will be the product of choice shortly. The data we have in those highest risk groups that we've talked about, congenital heart disease, chronic lung disease, and extremely premature babies under 29 weeks gestation age. Obviously, we weren't able to do a placebo-controlled trial in these groups. These babies were receiving either nirsevimab or palivizumab, and the data showed that the antibody levels of nirsevimab should be sufficient to prevent disease, and that it seemed to be as good as palivizumab for preventing disease in this population. And I really am very comfortable switching to nirsevimab in these high-risk babies once it becomes available. We talked about the timing of the administration, so we need to give it really at the beginning of the RSV season in November for babies that are under 8 months of age, and then babies that are born during the RSV season will receive it potentially at their birth hospitalization. Because the reason for this is we know it lasts for at least 150 days, the protection, but we don't know if it lasts any further. Another exciting potential avenue for preventing RSV disease in all infants, but not necessarily in premature babies because they'll have been born before this intervention can be done, is vaccinating the pregnant person. And therefore, these are not monoclonal antibodies, but a protein subunit vaccine given to the pregnant person. The pregnant person then develops their own antibody response against RSV and passes on those antibodies to baby. And as I said, the bulk of those antibodies get transferred after 35 weeks. And what the studies have shown is that babies are born with high levels of antibodies against RSV when the mother has been vaccinated like this, and those antibodies will decline over the first 6 months, but that during the first 6 months of life, this approach has been shown in randomized controlled trials to reduce the risk of RSV medically attended disease or hospitalization in the range of 50 to 80%. So maybe not quite as good as nirsevimab, but still really great. So this is another potential approach. So one of the reasons that NACI has not yet provided recommendations on nirsevimab is that we are going to, in the spring, publish recommendations for the use of both either nirsevimab or the maternal vaccination. And the reason that there was that delay in part is because the maternal product is still under review at Health Canada, and we expect Health Canada approval for this approach probably by the end of this year or the first quarter of 2024. So once that approval takes place, you'll see recommendations on who should be getting the maternal vaccine, who should be getting nirsevimab, what's the most cost-effective way of doing this, and how we're going to use these exciting new products to reduce the burden of RSV disease in Canadian children. So just to wrap things up here, I hope I brought home the point that RSV is dangerous. It causes a substantial burden in our youngest infants, and also, in particular, those infants with high-risk conditions for severe RSV disease that we've talked about. But there are everyday things that we can do to protect ourselves from RSV and reduce the risk of this happening. And there are monthly injections that are currently available for our very high-risk babies, so Synagis, but be on the lookout for what your provincial recommendations are. And it's possible that these recommendations are going to change when nirsevimab, the long-acting monoclonal antibody, becomes available in Canada. So that's all I have to say, other than some people often ask me, what's going to happen this year? Is the RSV season going to be as bad as last year? Is it going to be, well, we never really know, do we? And my crystal ball is a little bit muddy. I think that probably this year is going to be a typical year in terms of respiratory virus, the seasonality, the timing of it, and the amount of disease. But even a typical year is still keeps us pediatricians busy in the winter months. So, and we're already starting to see some RSV circulating here in Montreal. We've had a couple of hospitalizations here, and our positivity rate has been creeping up. So it'll come this year, and hopefully not nearly as bad as last year. But we still need to be protected. And if your child is eligible for the prevention, please inform yourself about it. Make sure that you're getting it. And also for children who are eligible, so 6 months of age and above, for influenza vaccination, it's highly recommended, especially when they have underlying medical conditions. So thanks, and I'm happy to continue this discussion.
Okay, Dr. Papenburg, thank you so much for your presentation. Very important topics for families, and we have a few questions from our social media. I will start with one from Dale Lee from Calgary. She asked about, it means not going out, because you're talking about how to protect your baby and prevent babies from getting sick. Does it mean not going out to buy a fridge, grocery, etc.? Because this is something that parents are always aware of. Should we not go out at all? But also we always try to balance with the parents' mental health, especially after a long NICU stay.
Oh, for sure. There's no one right answer, I think, for all families, right? I think different families are in different situations with regards to how much help they might have at home from other, extended family. There are single parent situations as well. So there's no one size fits all answer to that. But I think we just have to understand that the more exposures that the baby has, that every exposure comes with a small risk, but the more you expose, then the more these risks add up. And also not every exposure is the same. It's one thing to be if you're going to Costco on a Saturday at 11 o'clock in the morning, things can get pretty crowded there. So as opposed to maybe other situations where, there might not be the same number of people and the same density of people as well. So I guess I don't know if this is a satisfactory answer, but we have to, I think, people need to be able to live their lives, and your mental health is important, and getting out with baby is important for everybody, and happy parents help to have a happy baby. So we don't want to do things that are going to make us get cabin fever and be overly anxious. But just understand that, what are the risks? What are the situations that are more risky? Again, a toddler birthday party with a bunch of 2-year-olds and runny noses and with no hygiene, that is that's a high risk situation. So we have to understand where the risks are, and then make decisions as to what are the ones that we feel okay with versus maybe we'll pass on that opportunity until baby's a little bit older.
Absolutely. And this also apply for the holidays, because all families always ask, how holidays are approaching, Christmas, Hanukkah, all the holidays in December, and families are always, should we go? Should we not go? I'm going to offend my mother-in-law. So we actually have a letter for the families to present to their relatives on the risks. So what is your take on the holidays? Because it's very important for families to stay connected, to celebrate with a celebration, but with these fragile babies. So what is your opinion as a pediatrician on that one?
I think that, obviously the younger the baby and the higher risk the baby in terms of, how prematurely were they born, how rocky was the NICU course, how long were they intubated. These are things that are going to make me think that the lungs may be, how how immature are the lungs, and how much damage did they get from being on a ventilator for a long period of time. And then obviously if they have bronchopulmonary dysplasia, so all of these pieces of information kind of add up. Well, how risky is it for this particular baby? And for a baby with BPD in their first year of life, you just have to be so careful. I think I just can't. It's hard to crush people's Christmas or holiday season, but try and find other ways to connect. Now we have Zoom, we have other ways, or meeting outside, going for a stroll in the park and having hot chocolate or something like that. Ways to connect that maybe won't have the baby indoors with other kids running around and uncle, the 5 different uncles and cousins and everybody coming and wanting to show their love to the baby. But really, every one of these contacts is going to increase the risk. So again, there's not a one size fits all, but the more all these things are kind of entering my mental calculation, how old is the baby being probably the number one thing. Like once they're in their second year of life, with the exception of BPD, we can breathe a little bit easier. But those first months of life, if they have any of those chronic conditions, I just feel that it's not worth risking a hospitalization for RSV.
Okay. So the next question we have here, if the parent is sick and we don't know if it's RSV or cold or whatever, or the respiratory virus, and the parent is breastfeeding, should they continue to breastfeed the baby?
So I didn't mention this because I realized that breastfeeding is not every family is able to. Not every parent is able to offer that, right? But we do know that breastfeeding is actually protective against most viral respiratory infections. Obviously it's not 100% protective, far from it, but it does reduce the risk of infections due to the passing of antibodies in the breast milk. So breast milk is protective against infections, but if mom does have signs of a cold, I would suggest continuing to breastfeed, but to wear a mask during breastfeeding. The mask is going to cut down on the risk of those droplets getting into baby. And obviously you're so close for so long. I understand that it's no fun to be wearing a mask at home. But and I also feel that there's no downside. Wearing a mask for a few days while you're symptomatic is not going to affect the bonding that you're going to have with your baby. It's just going to reduce the risk of passing on that virus, whichever one it is, to baby.
So next question, what is the long-term impact on the premature lungs if the baby does have RSV?
That's a great question that is being debated a lot in the literature. So there clearly is an association with early life severe RSV infection and later development of asthma, or recurrent wheezing disease. What's less clear is, was it the RSV infection that somehow either damaged or caused like an inflammatory response that later on that triggered this predisposition to wheezing and asthma during their early childhood? Or do babies who are going to become asthmatic eventually already have twitchier airways and will wheeze more, and their bronchioles will constrict more easily when they get an insult? And when they get that RSV infection, they get sicker. So is it the chicken or the egg is part of the big debate. So right now I can tell you that the WHO, the World Health Organization, says there's not enough evidence to say that RSV causes asthma, severe RSV disease causes asthma, but there are some experts in the field who disagree with that opinion. So bottom line, I think that I'm most concerned about the acute problem that could lead to an emergency department visit or a hospitalization due to their RSV infection. That's my number one concern. But also, it's possible that by preventing a severe RSV infection early in life, that we're also going to maybe have less of a risk of developing asthma later on. But that's a maybe.
Okay, so one question about, because you talk about going to emergency room, when parents should seek medical help or when they should call 911.
Okay, so that's an excellent and very practical question. So I think that parents should think of the warning signs for their baby are obviously if any baby in the first 2 months of life who has a fever, you should seek medical attention. Even if they have a runny nose and they look like they have a virus, during those first 2 months of life, any fever could represent a bacterial infection that requires antibiotic therapy. And in young babies, those bacterial infections can spread faster and they're more vulnerable to those bacterial infections. So fever in a child under 2 months of age, or even under 3 months of age, certain pediatricians would say that should warrant a medical visit no matter what, okay? No matter how well the baby may look. Then it's a lot of things have to do with how is my baby doing overall? Are they just becoming more and more lethargic, less energy, not drinking well, not waking up to feed as well? These are all warning signs that the baby should be evaluated by a physician. Another thing is, are there signs of dehydration? Is my baby's diapers, are they still wet and heavy, or have I noticed, I've only had to change my baby's diapers twice in the last 24 hours and it was light? Well, that shows signs of dehydration. They should also be evaluated. And then finally, there are signs of respiratory distress that should prompt a medical attention. So we talked about the cyanosis, or in other words, if the color of the child has changed, either being very pale or to being kind of purplish around the mouth, that should require purple around the mouth should probably require a 911 call. If the baby has stopping breathing for extended period of times, we know babies can have what we call periodic breathing. So they'll breathe a bit faster and then they'll slow down. They might even pause for 5-10 seconds. But if you're having long pauses beyond 15, 20 seconds, that's when you should probably be calling 911. And if the baby is working very hard to breathe, so signs are nasal flaring, so the nostrils are flaring. If there's tugging above the sternum, indrawing in between the ribs or under the rib cage. If your baby's breathing fast and having a hard time breathing, you need to bring the baby in as well. So these are, I would say, the red flags that should prompt medical attention.
Thank you so much for that. So now let's move on to the antibodies, because we have some questions here. From Halifax, does the vaccine have side effect? I'm not sure she's asking about the maternal vaccine or the prophylaxis, but let's discuss both as you are here.
Sure. So, Synagis or palivizumab has been used in Canada for over 20 years, and it's an extremely safe product. There are very rare cases of allergic reaction to it, and that's probably like the only kind of worrisome side effect that you can have, but they're extremely rare. As with any sort of medication or vaccine, there's always a chance of rare allergic reactions. Really a super safe product, Synagis, and we know it inside out. Now, the newer monoclonal antibody, we don't have nearly as much experience, even though it's been studied in thousands of babies. But it is such a similar product to palivizumab in terms of being a monoclonal antibody against exactly the same fusion protein. And the data from the randomized control trials showed no concerns about any safety signals. I feel very confident that also it will be a very, very safe product. I don't anticipate any sort of serious adverse events beyond the very rare case of allergic reaction with this monoclonal antibody. So like I said, we know one of them inside out over 20 years, thousands of babies in Canada, tens of thousands of babies in Canada have received it. It's super safe. And the newer one, very similar. I expect it to be very safe. The studies have been shown nothing but reassuring news for that. Now, with regards to maternal vaccination during pregnancy to protect the young infant, so that's not yet available in Canada, and it won't be available this year for sure. So we don't really have to worry about or think about that too much, but it seems to be very safe. The one concern was a non-statistically significant increase in the number of premature deliveries that occurred in the persons who received the active product, so the vaccine compared to placebo. And so it wasn't, it was an increased risk, but it was relatively small and it wasn't statistically significant. So in other words, we don't know if this was just a random occurrence, just the way the data played out. And if they had continued the trial for and continued to enroll twice as many patients, then we would see that there actually is no difference. Or is it a real difference that if they would have continued with several thousand more patients, then it would have become statistically significant? There's no way we're going to know for certain right now. But the reason I think that it might be real is that there was another product that was studied, not by Pfizer, but by another drug company called GSK, in pregnant persons as well, with the same goal. And there was a statistically significant increase in premature deliveries, but in a way that we don't understand why yet, only in low and middle income countries. So I think that there might be something there. Now, what has the US FDA done to try and mitigate that risk? What I thought was actually quite bright is it's only authorized in the United States to be given from 32 to 36 weeks. So if there is a propensity for the vaccine in a small number of cases to increase the risk for premature delivery, if you're only giving it after 32 weeks, you're kind of outside of the range of premature delivery that would be very dangerous. And actually, the deliveries that occurred prematurely were on average 4 weeks after the injection. So it's not an immediate phenomenon either, if it is indeed true. So I think by giving it late in pregnancy, we're not going to really run into any sort of trouble with this premature delivery. Health Canada has not yet said when it will, it has not yet been approved by Health Canada, or we don't know what their time frame is going to be for what gestational age it'll be given. But I suspect that that Health Canada will probably follow the FDA's lead with regards to that. So that's the only safety signal that I can say, and I think that we're doing things to mitigate that risk, or to if that risk is real, to try and make sure that it doesn't lead to consequences for the families that choose to get vaccinated that way.
Absolutely, because it certainly is a concern. They deliver baby premature, whatever gestational age that is. So let's continue this conversation when the time comes, when the vaccine is actually in Canada. So there's another question here. Do you have the choice between the two prophylaxis for premature babies under 25 weeks gestation?
Well, currently there's only one product available in Canada, the tried and true Synagis palivizumab. When nirsevimab will be available, and when your province is using it, I expect that it will be a switch over from palivizumab to Synagis, because of the great advantage of that only need one injection to cover the whole winter season. And also, I don't think I mentioned this, but nirsevimab costs only $500 to $1,000 for a single dose, so much cheaper than palivizumab as well. So it works at least as well, maybe even better in my opinion. You only have to give one dose, and it's cheaper. So there's really, I don't from looking at the evidence objectively, I really could not recommend to anybody to get palivizumab once nirsevimab is available. So I don't think people are I think that the provinces are probably not going to be offering that choice, but that has, I guess, yet to be determined. But I don't see why we would choose, why an individual would want to choose palivizumab over nirsevimab?
Well, we actually did recently, as you know, we did a survey with parents, and parents to understand what they know about RSV, how they would like to receive knowledge about RSV. And we ask them how they feel about what is available and what is coming. And the parents, they really ask questions about efficacy, safety, and the frequency of injections. So I think though we will have this conversation up in November when we're going to be talking about the survey. And for everyone who have questions about nirsevimab and palivizumab, we have a webinar coming up on Tuesday with Dr. Jesse Papenburg, and is free for registration. And people can ask all questions about, we're going to really dive into the options in Canada. It is targeted towards healthcare providers, but parents, if they're curious, they want to learn more. I know Dr. Jess is going to go through a lot of the evidence, so you can join his webinar on Tuesday. So the registration is free on our website. And I think we are okay with questions right now. Let me see. There is one more question that came to us.
Yeah, I'll just finish up also on the, just because I was comparing palivizumab and nirsevimab, but in the case of a premature baby, obviously premature babies at 25 weeker, for instance, even if the mom, it would have been too early for if we have maternal vaccination next year. Maternal vaccination won't help premature babies. Mm-hmm. The premature babies will still need the monoclonal antibody because they won't have had time. Either it'll be before the mother got the injection, or the mother wouldn't have time to have mounted the antibodies and pass them on to baby. As we mentioned, that babies are born prematurely, they don't have that passive transfer of antibodies. So the maternal vaccination is not really a way to prevent RSV in premature babies.
Okay, one more last question. When do the babies receive the prophylaxis? Is it on their actual age or their the corrected age?
So they are eligible based on their gestational age at birth. So depending on how premature they were at birth will indicate whether they are eligible to receive it. And then most provinces, it has to be within their first 6 months of life at the start of the RSV season. So if they're young enough, under 6 months of age at the start of RSV season, or born during the RSV season, and if they're premature enough according to the gestational age at birth. And that cutoff for gestational age at birth varies across provinces.
Right. So at the moment, late preterm babies do not qualify for the prophylaxis unless, as you mentioned, they are high risk and they go to this the scoring tool to see if they are high risk and could receive the prophylaxis when they are 32 to 36 weeks or 35 weeks.
Yeah, 35 inclusive. Yeah. But that also varies from one province to another. For instance, in Quebec, it's under 33 weeks, period. No, there's no scoring tool for late preterm infants. So families really have to look at their province's indications. And thankfully, the CPBF website has that nicely laid out.
Thank you. And we are updating as information becomes available. So we are updating the criteria. Dr. Papenburg, thank you so much for joining us here today to shine a light and inform families, because families, as I mentioned, the survey, they really want information. They want to understand what are the options, how to protect their babies through this season. So I'm very grateful that you join us here today. And again, on Tuesday, 2 p.m. Eastern Time, we have a webinar with Dr. Jesse Papenburg talking about strategy, including the potential use of long-lasting monoclonal antibodies. So registration is open on our website. So Dr. Papenburg, thank you so much for joining us here today.
It was my pleasure. Thanks for having me.
And to all of you watching us live today, thank you for joining our Preemie Chats, and a special thanks to our sponsor AstraZeneca for making education sessions like this one possible. And just a reminder, if you missed part of today's session, head over to canadianpreemies.org to see this episode and all past editions of the Preemie Chats. You'll find many resources and support options available there. And you'll also be reminded that CPBF is a charitable organization and depends on support to continue its important work. Consider how you can support CPBF and its mission to empower families of premature babies in every step of their journey. Together, we can create a brighter future to all premature babies and their families. And we'll see you again next Friday, 1 p.m. Eastern Time. Stay well.